Dear colleagues and friends, I'm happy to be here. Thanks for organizing committee for inviting me to give this talk. Last year in Ljubljana, I talked about treatment of patients with thoracic complications after big thoracic surgery. But today I try to focus on the some prophylactic measures in specific situation of surgery. According to the rule, I have to announce that I have not any conflict of interest. And I want to start my presentation from the presentation of this horror of thoracic surgery. This is bronchopleural fistula with empyema after right side pneumonectomy. And this is the most difficult complication in thoracic surgery as far as I understand. How often do these complications occur? We have found some publication and the incidence of bronchial fistula till 1 to 12% occur in the population. We found a few papers about TB surgery which showed that 0.6 till 16% of bronchopleural fistula after lung resection and pneumonectomies we could check this complication. What the reason? There are some reasons, and obviously bronchial stump insufficiency is often present on the right side and rarely on the left side due to anatomical reasons. We found a few experimental trials devoted to the method of prophylaxis of bronchial stump problem. In one of them, as you can see here, authors compare different techniques of bronchial stump closure. At the end, they could not define the best method. We found also some trials which showed that incidence of bronchial fistula occur more often in patients with active endobronchial TB. From the other side, bronchial stump reinforcement with muscle flap decreased the incidence of the life-threatening situation. The same results were shown after multivariate analysis. According to Pomeranz publication 20 years ago, bronchial stump reinforcement with muscle flap is recommended for cases with preoperative sputum positivity, polymicrobial space contamination, and presence of preoperative bronchial fistula patients. Historically, mass and omental flap are well described method coverage of the bronchial stump. Here are some variants of muscle flap. You can use latissimus, serratus anterior, and other muscle presented on this figure. For a long time, Omentum was used as the best material for bronchial stump reinforcement in oncological surgery after lung transplantation. Nevertheless, we could not find any recommendation for omentoplasty in patients with TB and other infection diseases. Which flap are used more often? As you can see on the next slide, in 60% surgeons have never used any reinforcement measure for bronchial stump protection during the last 15 years. Other muscles were used in the equal proportion, 13–14% only. But now I want to show this particular patient, and it is a really big problem. What mask could be used in this malnutrition patient? There are some differences between these two types of patient, and as a rule, we have make a really difficult choice for chronically ill patient, for example, TB patients. So that is why I speak today about diaphragm flap as a last stand before empyema in patient with require right pneumonectomy due to the destroyed lung. Now I will show you the results of our retrospective cohort trials and the outcomes of right pneumonectomy for pulmonary TB patients. The aim of this study was to make comparison of the efficacy and safety of diaphragmoplasty for the main bronchus reinforcement after pneumonectomy for mycobacterial pulmonary diseases. We performed 131 pneumonectomies during the last 4 years, and 21 patients was, according to decision of multidisciplinary team, put it in this group for reinforcement. 14 males, 7 female, middle age 40 years. All patients had malnutrition. All patients were treated with anti-TB drug more than 2 years, at least 2 years and more. All patients had totally destroyed lung. Primary pneumonectomy was in 57% and completion pneumonectomy in 43% of cases. All patients were divided into groups. In 30 patients, group 1, the first group, diaphragmatic flap was used. In the second group, 6 patients were operated with latissimus dorsi and 2 serratus anterior. Let me show some technical tricks of formation of mask flap of diaphragm. At first, diaphragmotomy should be done. After that, we can observe on the left side, you can see the schemes of this operation and the direction to make this transplant a little bit longer. It depends from the case. After diaphragmotomy, we can observe subdiaphragmatic space and estimate the possibility of diaphragmoplasty. Next, move in the transaction of diaphragm step by step along the virtual line, which you can see on the scheme. It is very important to visualize and save the vessels for normal nutrition of this flap. It is very important to visualize and save the vessels. I just told about that. And this is our flap. And in 1 minute, it will be ready for putting in the mediastinum. Flap should be positioned on the mediastinum and should be fixed on the trachea, right main bronchus, bifurcation, left main bronchus, and peribronchial tissue to cover the bronchial stem. Last step in the suture of the diaphragm wound. Just I want to, this is preparing of the flap. Sometimes the wound of diaphragm looks like too big, but without any problem, in all cases, we could suit it after preparing this flap. And this is very important things to put this flap around the bronchial stump. You have to fix this flap not only for the suturing line, but over the flap, to put it inside of this flap. This is a very important thing in this manner. Sometimes surgeons are facing the problem with diaphragm approach. On this slide, I want to show you the better access to the diaphragm by additional thoracotomy with skin incision. And sometimes we can perform the same approach without initial skin incision. In Russia, this method is named after overhold. I prefer this technique almost in all cases. The results are shown on this slide. Statistical significance was only in duration of surgery. Diaphragmoplasty associated with longer operative time. There was no differences in blood loss, postoperative morbidity. There was no lethality in both groups. Overall operation time was shorter than in group 2. Insufficiency of the bronchial stump was found in 31% and 37% in second group, respectively. Difference were in the formation of bronchopleural fistula. This condition occurs less frequently in the diaphragmatic flap group. This is the point, insufficiency with fistula and without fistula, and it was statistically very important. So, if summarize the results of our investigation, diaphragmoplasty in comparison with other flap associated with high operation time, same incidence of bronchial stump insufficiency, same morbidity, same blood loss. Nevertheless, the majority cases of bronchial stump insufficiency were ended without fistula. Now I want to present you 2 clinical cases. One of them, it was a female with bilateral cavity disease and subtotal destructive lung. After intensive preoperative conservative treatment during 6 months, right pneumonectomy was done. Early postoperative period was uneventful, but later we have found fistula, but diaphragmatic flap saved this situation. The patient was discharged on the 72-day surgery without bronchopleural fistula. And the second case is very similar, but the patient was non-tuberculosis mycobacterial destruction lung, and the process was unilateral. The right lung was completely destroyed. Right pneumonectomy with diaphragmoplasty was performed, and this is endobronchial picture of the 7th postoperative day. 1 month later, the bronchial stump insufficiency was revealed. Patient was discharged on day 89 after surgery without bronchopleural fistula. And 1 month later, you can see endobronchial suture. In conclusion, let me summarize. The diaphragmatic flap for bronchial stump protection after right pneumotomy is an effective and safe procedure. Diaphragmatic flap could provide lower incidence of bronchial fistula in cases of bronchial stump insufficiency in comparison to other flaps. Additional trials are necessary to better understand this situation. And I want to thank you, and I want to announce that next conference, World Cardiovascular and Thoracic Society will held in St. Petersburg. You are welcome in St. Petersburg in September 2020. Thank you very much for your attention.